Welcome to the Tenex Health Educational Webinar Series. Shortly, our invited physician will begin their session.
Well, thank you, Juggy, and thank you to Tenex for giving me this opportunity. Just to clarify real quick, I've been doing the technique for 2.5 years now, and it's been such a great technique and it has been very beneficial to my patients. I'm really excited to talk about it tonight. As Juggy said, I'm working with Lourdes Health System in South Jersey. With respect to my audience, I wanted to talk about disclosures. I have received honorary compensation for speaking engagements from Tenex, and these have all been meeting the ethical standards of my health system. So moving on tonight, obviously we're going to talk about the technique. Second goal, we're going to be talking about patient selection and expectations, and also touch on who not to do the procedure on. And thirdly, talk about some ways of how I've incorporated the Tenex Health technique and how I've been able to grow it in my aspect of non-operative sports medicine. So when I first heard about the technique, I had been practicing non-operative sports medicine for about 5 years, and I was becoming very frustrated with the current treatment options. They weren't meeting my expectations, my patient expectations. So when this technique came out, I thought it was it caught my attention, because if I could be able to target a diseased tissue through a technique that was minimally invasive, safe, and effective, I thought it was rather intriguing. So it did spark my attention. Thirdly, the published data that was needed to get approved through the FDA was superior to the current treatment options that I were offering my patients. So it definitely had my attention. So I quickly continued to read the literature and was really on board right away once I started to offer this treatment to my patient and see the effects and the outcomes that I was getting was what the published data was supporting. And we'll get into that later. First and foremost, why I adopted the procedure was I was very comfortable with ultrasound-guided procedures. I had been doing ultrasound-guided procedures for a number of years, and I feel like to be able to adopt this technique, you have to be well-versed and comfortable using ultrasound as a treatment modality. So what the company did is they took, for example, the traditional approach of accessing diseased tissue, as depicted in this middle picture here. The traditional approach for the tennis elbow is the 1 to 1.5 inch incision to expose diseased tissue for treatment. They thought of a way of using ultrasound guidance and minimally accessing the tissue through a small 3 to 4 millimeter incision, and through ultrasound guidance and a handheld device, we're able to gain access to diseased tissue and offer a treatment. So the role of tendinopathies, if you're practicing any type of musculoskeletal medicine, whether orthopedics, PMR, non-surgical, non-operative sports medicine, as you know, they're very, very common. So there are, in my book, a ton of tendinopathies in various regions of the body that are opportunities that you can help a patient that has been battling a chronic problem and improve their pain and function. So Tenex has their system here, the console on the left with the handheld microtip on the right. And the unique thing about this technique, this technology, is that the console is delivering the energy required as well as the power necessary to treat the diseased tissue. And at the same time, it's a continuous cycle that it is aspirating as well as irrigating through the needle-held device, the microtip. A closer lookup of the microtip, the TX1 microtip, it's the size of an 18-gauge needle, roughly 1.25 inches in length. And the nice thing about this technology is that it's an ultrasound-driven procedure, so it's much like seeing a needle when you are targeting the diseased tissue. And that's why using the ultrasound is very important, so you can correctly identify diseased tissue and treat the affected area while not bothering normal tissue. The device is set up in such a way that you have to work at it to hurt good tissue. But it is a rhythmic type of procedure, a jackhammer type approach, but it's not like you're jamming it into the tissue. It's a finesse procedure, a rhythmic type of back and forth movement, debriding, taking away the bad tissue. And as I said before, it's a continuous cycle where it's irrigating with normal saline, because ultrasound energy with time will get very hot and then can damage and hurt the patient. So that's a cooling effect through the irrigation, and at the same time it is aspirating. Just one of the many examples of diseased tissue, the provider here on the left side is identifying the lateral epicondyle, and in the top right corner you have the traditional tendinosis signal, which is a lack of signal, the dark region which is labeled. And then moving down, as the handheld is placed through the small 3 to 4 millimeter incision, you're able to identify the diseased tissue and target it through the treatment. And this is instituted by depressing a foot pedal mechanism which supplies the energy to activate the technology. And lastly, in the bottom right, as you are doing the treatment, you often will see a crystalline or snowflake appearance directed at the target tissue. And that's a good sign that you are making an effect in the diseased tissue. And that is something that is commonly seen, especially with tennis elbow cases. Again, moving on, these are just some pictures of technique, patellar tendon access through the longitudinal view. You can see in the middle row of pictures diseased tendon for the patellar tendon as well as the plantar fascia. Again, the hypoechoic or anechoic signal demonstrating the tendinotic tissue. And then in the bottom, the post-procedure results, which in my practice I am rarely doing post-procedure ultrasound images. Okay, moving on, which I think is another very important piece to the talk, is patient selection. First and foremost, in my book, they need to fail appropriate conservative physical therapy treatment. And another thing, what I would add to that is that they've gone to excellent therapy. We all know that not all physical therapists are created equal. So that's usually up to the provider, the clinician, to make that determination. And they've tried traditional things such as the rest, the ice, the bracing, and anti-inflammatories such as Motrin. In my book, I don't think they necessarily have to have a steroid injection, but if you've been doing musculoskeletal medicine long enough, they often come to you and they've had 2, 3, or 4 steroid injections to the diseased tissue. That is a very common practice, which I try to avoid at all costs. Because of the studies that reveal that repeat steroid injections can actually cause more harm than good. Often the diseased tissue corresponds to point tenderness on a specific body region, For discussion, the lateral epicondyle is a perfect example. And then to proceed with the procedure, I make sure that we have some type of documented tendinopathy, and that can be done through ultrasound as well as MRI, demonstrating the diseased tissue. Before I go on, another important thing to mention is who not to do the procedure on. And this is pretty straightforward in my book. It's the patient that is not willing to pursue physical therapy. That's a prime example. That's somebody to be very cautious about not performing the procedure on. A second example would be somebody that's not willing to follow your treatment protocol. And what I mean by that is if they're not willing to protect the area and allow healing to occur 4 to 6 weeks after doing the procedure, then this is somebody that you should not even entertain the technique with. Thirdly, I think this is important, and I always exercise caution with patients that have psychiatric issues. I think that's something to always be cautious with. You know, for example, obsessive compulsive disorder. It can be rather frustrating for the patient and also for the provider with certain psychiatric illnesses. So I just would exercise caution with that. So patient expectations, from my rule of thumb, are the most important thing, and often, every time we consider the Tenex Health technique, we talk about what the data supports, and I clearly state this. And what I'm talking about is pain and function, what their expectations are. And I always go back to the data and document that on average the success rate is around 80% improvement with regards to pain and function. And I clearly state that. I also try to find out what the goals of the patient are. And also if they're going to be compliant. And that goes back to who not to do the procedure on. If they're not going to be willing to follow the protocol, then I would not perform the technique. You know, some patients, they think that you said that they were going to be completely pain-free. So again, you want to go back to what the data supports and stay with that. The nice thing about the Tenex Health technique is with the correct patient selection, I'm often surprised if the patient is not going to respond. If you do your homework and correctly identify diseased tissue and that is the primary pain generator, it's often a positive experience in that you're helping the patient with regards to pain and function. Lastly, to all my patients at baseline, I have their pain scale, and whether it's an upper extremity or a lower extremity case, I will involve a lower extremity functional score or a DASH score for the upper extremity. And I find this very helpful, especially with follow-up visits when they're 6 weeks out and they might be questioning whether or not they're better or not. I often will use this these tools to get some objective data, and it's quite amazing the results that you will see because pain can be subjective. So since I've been doing this procedure, I've stopped counting. I've done 250 plus cases, but what's more important is not quantity. I really stress the importance of quality, and that should be all of our goals as providers, is just focusing on quality, because it is a procedure that is a finesse type of procedure. It's not a just line them up and do tons of procedures throughout the day. It is a finesse procedure and it takes time. I really believe in mapping out the area before you even start the procedure. This saves me a lot of headaches. On average, I do around 4 to 7 cases per week. One of the big ways that I've been able to incorporate and grow the procedure in my practice is reaching out to my current referral source. And it makes sense because these are the providers that trust you anyways. That's been a big win-win. Also, lecturing on the topic to physicians or physical therapists has been very beneficial. Another positive experience has been allowing providers to come and shadow me while I do the technique, as well as having therapists shadow me, and also have the therapist come in and see me on post-op days, the results of what the patients are getting and what they're saying. And to me, that what the patient's experience is has more value than what I say. So that experience has been very, very helpful in growing my practice. And of course, the traditional stuff. The newsletter has been beneficial that I have out to my physical therapists, as well as in my office setting, announcing the new procedures that I'm doing, in this case, the Tenex Health technique. This procedure, as many of you know, is a well-tolerated, and it's very cost-effective compared to the traditional approach. During the procedure, often the patient will tell me they had no pain, or if any pain, minimal discomfort. They often ask me how long it will take. I often tell them it takes longer to set up the procedure and tear down than it actually does to take the procedure. On average, around 10 to 20 minutes to do the procedure. I've done all the major body regions from the shoulder all the way down to the foot. Post-procedure, often I don't even give them any narcotics. When I first started out, I was prescribing them thinking I was going to cause a lot of pain, but that was not the case. They get by with ice therapy and maybe some Tylenol or an anti-inflammatory like Motrin. For upper extremity, I'm still holding true to holding off on repetitive activities, because that's usually what got them into the problem, developing the problem in the first place, and also avoiding lifting anything greater than or equal to 5 pounds. For lower extremity, plantar fascia or Achilles, depending on how much procedure time I do, they're in a fracture boot for 1 to 2 weeks. For patellar tendon, for the knee, they're in a knee lockout brace with crutches for 1 full day. And then with each preceding day, they advance 10 degrees of flexion. For my elbow cases, I encourage them to do range of motion the day of the procedure, after the procedure is performed. And the same holds true for shoulders. They're only in an arm sling for 1 full day, and then after that, they start a gentle range of motion program. These are just some pictures depicting ultrasound placement of the probe and targeting the tissue. This case, again, is tennis elbow, and in the bottom you can see the diseased tendinosis signal on the bottom right-hand corner. Again, probe placement for patellar tendon. Achilles tendon, healthy and diseased tissue at the top part, and at the bottom part, diseased tissue where you have thickening and the hypoechoic signal. And then, of course, plantar fascia. So that is the end of my discussion. I wanted to thank you for your guys' time and open this up to any questions that you may have.
Well, Tom, this is Juggy. Thank you again for always giving very clear presentations. What I would ask is we're going to kind of have questions posed to Dr. Plut 2 ways. So for the participants, if you wish to have a question, you have an opportunity to type it in, and Dr. Plut will have access to that. And Tom, once you get those questions coming your way, if you could read the question and then your response. And then we will also open up the microphones here in about a minute or two, so if folks want to answer questions or deliver questions to Dr. Plut directly, they can. And then Tom would obviously be able to give his response. Maybe as we're waiting for people to frame their questions and get them out to you, Tom, I've got 2 quick ones that I think hopefully you'll be able to give some clarity on. Of the over 250 plus patients you've treated, could you share with the group what that percentage breakdown is in body part, number 1? And number two, you know, in terms of post-procedure care and kind of clinical outcomes, do you see certain body parts respond more favorably than others in your experience?
All right, so the first question in terms of the breakdown of body regions, you know, the majority of my cases are the elbows, knees, Achilles, and plantar fascia. You know, the smaller percentages are my shoulders because you have to be more patient selective for that with regards to body habitus because we only have an 1.25 inch length of needle. I also, some smaller percentages, I'm doing gluteus tendons as well as peroneal tendons in the ankle and foot. But those are the smaller percentage. But a majority of my cases are elbow, knee, foot, and ankle, Achilles tendon, and plantar fascia. And Joggy, remind me your second question.
Yeah, as you've done these, are there kind of, you can share the percentage of success on those different body parts, and maybe add to that. You touched on this a little bit. As you reflected on your experience, are there certain patients that present themselves that you know now would not be good candidates for Tenex? So kind of question 1A is the success rate in the different body parts, and then 1B is if you could profile the patients that you think would not be ideal candidates for Tenex as they present themselves.
Okay, okay. So the ones that have been the most successful for me, from my perspective, have been my elbow cases. Patellar tendon has been quite amazing. Achilles tendon and plantar fascia, often those have been in some ways very, very successful, but then in other ways, depending on the amount of pathology, because there can be some significant tendinopathies with Achilles tendon and plantar fascia, they sometimes have not responded as favorably as I wanted to, but at the same time, I always go back to the data, and on average, I think it's holding true to the 80%, but there are people when they are complicated and they've had issues for 5 to 10 years, some of them are only getting maybe 50 to 60% success rate, or they might, or to get to that 80%, they might take a lot longer to get there. For example, the plantar fascia cases, sometimes you have to use a lot more energy than what we before what we anticipated that was needed, and those ones take a little longer to get better. In terms of looking back on maybe, you know, from my experience that we maybe shouldn't have done the procedure, or it would be if they have a significant tear in the tendon. So for example, the extensor tendon for the lateral epicondylosis, you know, if they have a 50 to 75% tear in the tendon, those cases, they might not do as well. That's one thing that comes to mind. I think that answers your question.
It did, yes. Thank you for that. As I'm seeing some of the questions roll through, Tom, I'll take your license and kind of pose those questions to you, and then you can respond to everybody listening in. One of the questions that's come through is, do you need to be proficient in ultrasound to do the procedure? So if you can elaborate your ultrasound proficiency and what you would tell others interested in doing this.
Yeah, so as I started at the beginning of the talk, I really believe for this technique to be successful for the provider is that they have to be, they have to understand ultrasound, and they have to be comfortable with it, and they do have to be proficient. You know, this isn't just a blind technique. It's an ultrasound guided technique, and I think that is very important for being able to be successful at this technique and provide the maximum benefit for the patient.
Good, thank you. One of the other questions is I'm just reading through as they come through from the audience here. is that what's your experience been with any repeat procedures? And do you feel that you need to do sometimes repeat procedures for patients that have not been successful?
Okay, yeah, great question. So when I first started doing this 2.5 years ago, I think our current knowledge was, don't go over 2 minutes in the body region. And looking back and how I'm treating patients now is I'm quite comfortable spending double that amount of time or even 5 minutes on certain body regions because it takes that amount of energy. For example, plantar fascia, I've had to do some repeat cases because out of concern of maybe hurting the patient earlier on when I started doing the procedure, I would spend less than the 2 minute mark because I didn't want to cause harm. But the more I've done, Juggy, can you hear me? I'm sorry.
No, I can hear you still. Thank
you. I got a weird sound. So as I've become more comfortable with this, some of those cases I've had to repeat, and I've had to come back and do extra energy. My rule of thumb is maximum 2 procedures. If they're not responding to the technique, there's no point in keep going down one particular pathway, in this case the Tenex Health technique. But often, if you didn't spend enough time the first time, they might be coming back with some issues that a repeat second can be warranted if, when you go back and look in your chart notes, that you see that you didn't spend enough time initially.
So one of the questions that's...
Juggy, let me say one more thing. When I approach a procedure, my goal is to go in once and once only. That should be everybody's goal. And that's why it's important that the importance of mapping the tissue prior to the procedure, meaning before you even anesthetize the area, you have accommodated for your probe placement, adjusting for the depth that's going to be needed. For example, some of these Achilles tendon cases, you might need to make 2 incisions above and below the lesion to successfully get all of the target tissue.
Perfect. One of the questions we get often as clinical trainers, as we're out exposing physicians that are interested in this, and I think hearing from you would be helpful. And it's a simple question, but what would you tell somebody if they ask the question, when do you know you're done, Dr. Plut? What would be your response and guidance for that?
Wow. So knowing, for example, this procedure is a finesse procedure, and knowing that I have spent well over 2 minutes in the body region and that it's still safe and effective, you will see a noticeable difference in tissue texture that you can only appreciate by having experience doing the procedure. And what I mean by that, there is a tactile type sense that you will develop that you can appreciate with the needle-held device, the probe against the tissue. For example, plantar fascia, when you first start the procedure, it is very gritty and it feels like you're hitting up against cement. I mean, some of these cases, the tissue is so thick because it's been there for years on end. So a lot of it, you're not always going to get the crystalline snowflake appearance for plantar fascia cases. So knowing how bad beforehand that the disease tissue is, meaning, for example, mild, moderate, or severe, is going to be a good indication that you might need to spend more than 2 minutes for a plantar fascia case. That being said, I would say, talking to my colleagues in the area, for some of these difficult plantar fascia cases, doing 4 to 5 minutes of ultrasound procedure time, I would be totally comfortable doing that, and that's not uncommon. And you will feel the tissue release and become soft and more mobile once you've done adequate treatment to the diseased tissue. So on top of the visual, there is a tactile sense that is appreciated, and that does come through experience, I must say.
Good. Thank you for that. There's another question that came through from the audience, and it goes back to the repeat procedures. So how soon would you consider doing a repeat procedure on some of these patients that weren't successful? Or
yeah, the reason I'm answering the question based on what the data shows. The data shows that the patient can still respond 4 to 6 months after the initial procedure. So with that being said, I hold to that, and I will not consider repeating until after that time frame has passed. And the reason why I say that, I've had patients 3 months out, and I just had a call the other day. Initially, a patient that we did her plantar fascia, she might have gotten a mild response. So I continued to follow her on a 4-week, 6-week follow-up basis, and then at the 3-month mark, she was 90% better. But initially, at the initial visits, it was very discouraging. But I kept telling her that it's okay, kept offering reassurance, and that with time, these plantar fascia cases often get better.
And was there any, on that, just elaborate, was there any other treatments that you subscribed to that patient during that 3-month period?
Yeah, that's another great question. So often with these plantar fascia cases, when you spend 4 to 5 minutes in the tissue, if you think about it, you're taking an 18-gauge needle basically, and debriding tissue. Well, what I think is happening is that you're actually creating a very large inflammatory cascade. So what I have found helpful to control that post-procedure pain is providing a prescription strength anti-inflammatory or a Medrol dose pack, a steroid pack for 6 days. I found that to be very helpful.
Awesome. Very good. On that point, there's a very interesting and detailed question, and I'm going to read it directly out here from the audience, Tom. And it goes as, Tenex is similar to needle tenotomy, and with that procedure, as you know, Tom, you're trying to induce an inflammatory response to heal the tendon. It's recommended to stop the anti-inflammatory medications 2 weeks prior to the procedure and also 2 weeks after. With Tenex, even though you are removing the necrotic tissue, do you think the normal body inflammatory response would be helpful in helping these patients repair the diseased tendon after the procedure? So I think it touches on what you spoke of, but if you could address that question, that'd be helpful.
Yeah. Yes. So I mean, a lot of the treatment options before Tenex, for example, I've done the prolotherapies of the world, the PRP. That is the treatment model, is that you want to create an inflammatory response in hopes of bringing in healing factors to promote healing. And I definitely think that has some value, but at the same time, if the pain continues to go on for a period of time, keep in mind they come back to me and it's been more than 5 days and they're still having pain, then I start to say, look, they've been in an inflammatory cycle. Now is the time to maybe consider bringing them out of that cycle, and that's where I can justify using an anti-inflammatory medication. Good. Very helpful.
One of the other questions here, Tom, if you can help answer, is that of your experience of the 250 plus procedures, if you can share with the group any of the complications that you have experienced.
Oh yeah, sure. I had a diabetic patient that had just a localized, to this day I don't know if it was a true cellulitis. I think at the time I might have been treating me and my brain by prescribing an appropriate antibiotic. That is I guess the only complication that I personally have had. To be honest with you, this patient did remarkably quite well, and she has sent me a few patients through word of mouth. She sent them my way. So that was the only thing that has really come to my attention. And like I said, that was more of a soft call. But in regards to complications like patellar tendon rupture, Achilles tendon rupture, I am not even concerned anymore. I had some concerns when I first started doing the procedure, but the procedure, if used appropriately, is not going to cause a tendon rupture. Another thing to remember when you're doing the procedure is it's not a harpoon. It's a gentle finesse procedure, a rhythmic fashion back and forth, and it's a controlled procedure. And you're using ultrasound guidance.
Good. Thank you for that. There's another question that is more on the technique. And the question is, do you try to visualize on ultrasound the microchip and the pathology at all times while activating the microchip?
The answer is yes, but does it happen all the time? No, because the current technology, you have to be within millimeters of the ultrasound beam to always visualize the needle. That being said, you can indirectly know where your needle is by sometimes seeing a fluid wave or the tissue being depressed. So to be honest with you, you're not always going to constantly see the needle. But before you're activating the pedal, you want to make sure you're in the area of diseased tissue, and that can be done through indirect signs.
Good, thank you. One of the other questions is, in your experience, how long should the patient have or be symptomatic before you offer Tenex? Your thoughts on that?
Well, yeah, so, I mean, these aren't people, the patient isn't the person that's come into your office and they've had plantar fascia pain for 3 weeks. That would be inappropriate to even maybe consider this invasive procedure. It is an invasive procedure, though minimally invasive. So often the patient that you're going to be selecting is somebody that's had chronic pain, 3+ months. But often they come to you and they've had pain and disruption in function for months on end, if not years. So their story will often tell you that what avenue of treatment you're going to go down. Obviously, if they come to you and they've had 2 or 3 steroid injections, I hope that the provider isn't going to consider another steroid injection. I think we should start to think about other treatment options.
Thank you for attending today's Tenex Health webinar presentation. I also wish to thank the speaker for providing a very informative session. For future Tenex Health presentations, please check with your Tenex Health representative.